I'd like to thank you for the opportunity for giving us the opportunity to talk about our work done here in Qatar. The title of the talk is Biomarkers of Neurodegeneration for Mild Cognitive Impairment and Dementia using Brain Volumetric MRI and Corneal Confocal Microscopy. Dementia is a progressive neurodegenerative condition, and early interventions can improve cognitive function, independence, and quality of life. However, diagnosis of mild cognitive impairment and early dementia can be challenging due to the insidious onset of the disease and gradual cognitive decline. That is why ADDF Diagnostic Accelerator Program has stated that there is a need for accurate and more reliable biomarkers for dementia. A good biomarkers can provide direct or indirect evidence of the underlying pathology of the disease, identify subtypes of MCI which do or do not progress to dementia, reflect disease progression, and it has to be accurate with 80% or higher sensitivity and specificity. Now, corneal confocal microscopy is a rapid, non-invasive ophthalmic imaging technique that generates in vivo images of the corneal morphology, nerve morphology. And we use software to analyze the fiber density, the branch density, and the total fiber length. It enables objective quantification of nerve morphology. It was pioneered for identifying diabetic neuropathy and subsequently has been used to study central neurodegenerative diseases, including dementia, Parkinson's disease, and multiple sclerosis. We've already published our first work, which shows that there is a significant association between the degree of corneal nerve damage and the severity of cognitive function and functional independence in patients with mild cognitive impairment and dementia. The objective of this talk is to investigate the diagnostic accuracy of corneal confocal microscopy and brain volumetric MRI for neurodegeneration to distinguish between healthy controls from patients with mild cognitive impairment and dementia. We have recruited patients with dementia, including Alzheimer's disease, vascular dementia, combined Alzheimer's disease, patients with mild cognitive impairment, and healthy controls from a geriatric clinic in Rumeila Hospital in Doha, Qatar. We excluded all the causes of central neurodegenerative conditions, all the causes of peripheral neuropathy, excluding dementia, dry eye, severe corneal dystrophies, and ocular trauma. The diagnosis of MCI dementia was based on the ICD-10 criteria, and patients underwent corneal confocal microscopy assessment, MRI, for brain volume quantification and cognitive function. Now, our demographic data shows that age, blood pressure, weight, HbA1c, and lipid profile, which could be potential confounding factors for corneal confocal microscopy measures, were comparable between the three groups, controls, MCI, and dementia. Now, have a look how the corneal nerves look like. These white lines here you see are the nerves, and this is how the nerve morphology looks like in a healthy control, in a patient with mild cognitive impairment, and a patient with dementia. Now, we quantify the nerve fiber density based on these main fibers indicated in red lines, the branch density indicated in green dots, and the total length of the fiber that includes the main fibers in red and the branches in blue. And our data shows that there is a progressive nerve loss in patients with mild cognitive impairment and dementia, as it's shown with the fiber density, the branch density, and the fiber length compared to healthy controls. When we look at the volume of the whole brain, intracorneal volume percentage, the hippocampus, and the cortical gray matter, we see that there is a significant reduction in the volume in patients with dementia compared to mild cognitive impairment and healthy controls, and the same with ventricular enlargement in dementia compared to patients with mild cognitive impairment and healthy controls. But there was no significant difference between healthy controls and MCI. When we apply ROC-CAP analysis to see the diagnostic accuracy of the corneal confocal microscopy, we see that to distinguish patients with mild cognitive impairment, the area under the curve for the corneal confocal microscopy measures would range between 75% to 81%. But with the brain volumetric MRI for hippocampus cortical gray matter, it was not significant. Only the whole brain and the ventricular volume area in the curve was significant, from 65 to 70%. When we look at to see the distinguished patient with dementia, the area of the curve for the CCM measures range from 72% to 81%, and for the brain volume MRI range from 79 to 91%. So to draw to conclusion, brain volume atrophy in MRI and corneal confocal microscopy saw progressive neuronal loss in patients with mild cognitive impairment and dementia, corneal confocal microscopy can distinguish subjects with MCI from those with normal cognitive impairment but not brain atrophy MRI. Our future work is to determine whether CCM can differentiate subjects with amyloid pathology in subjects with mild cognitive impairment and dementia, to assess the change in corneal nerve measures and brain atrophy in subjects with MCI and dementia over a 2-year period, and to compare the prognostic ability of corneal confocal microscopy and quantitative brain atrophy on progression from MCI to dementia. At this point, I'd like to thank our team, especially Dr. Hanadi, the director of Rumeila Hospital, and Professor Malik, the lead PI of the study from Cornell Medicine. Thank you.